Dr. Kisuule, thanks for being here today with us. What does it mean to you to be the representative of this model of hospital medicine on a global scale as elected president?
Yeah, well, thank you for that question. I will say it's quite humbling to be the face of hospital medicine for the Society of Hospital Medicine. It's very humbling, but yet exciting because as an immigrant born in Uganda, being able to come here to the United States and represent the fastest growing specialty in the United States, it's exciting for me because this shows other young African girls, other young girls in general, that they too can achieve. We are starting to see women more and more in leadership, but certainly not as many as men. And so every time that there is a woman rising to leadership, it is an opportunity to celebrate because it shows more young girls that they too can achieve leadership in their field. Well, I'm a living example of that. Certainly, at a society level, there are opportunities for women to be engaged, either at the national level by joining committees which they can lead. They can join special interest groups which they can lead. At a more regional level, there are chapters of the Society of Hospital Medicine, and there are several chapters that have female presidents. So, for example, the Maryland chapter, which is where I happen to practice, the current president of the chapter is a female. So certainly at the society level, hospital medicine can promote this leadership. But our field is more than just the clinical care of hospitalized patients. Certainly that's what we do in terms of practice, but we also lend our expertise to improving healthcare systems. So examples of that are developing the processes to improve quality of care in the hospitals, developing the processes to make the care of patients efficient. Because we have this expertise, more and more you're finding that hospitalists are being asked to be leaders within their hospitals. So you'll find that chief medical officers now tend to be hospitalists. Vice presidents of medical affairs are hospitalists. Division directors are hospitalists because, again, hospitalists in the inpatient side are also taking on the education roles for residents. So this field really does provide a lot of opportunity for women to engage in leadership. The United States, we absolutely have not achieved equity in care, largely because of the social determinants of health. And you find that the races most affected by this, at least in the United States, tend to be the Black, so African Americans, and certainly the Latinx community. In the United States, if you're hospitalized, the hospitalist, for the most part, is the physician or provider that is taking care of you. And so this field is a very powerful platform to look and see that we are providing that equitable care. And so there are some specific examples of hospitalists here in the United States who are making it their life's work to pursue social justice and break down barriers to care. And so in a recent article that I wrote, I shared an example of Dr. Cervantes, who really advocated as a hospitalist because one of her patients died because they were not able to get access to life-saving dialysis because they were an undocumented immigrant. So, she advocated to break down these barriers and make it possible for immigrants to be able to get this dialysis care in her state, which is Colorado. But hospitalists were in the position of seeing some of these things. And so, when we see these things, these inequities, we really have the platform to be able to advocate. My top Challenges as a president, that's a good question. I will say the biggest one will be that, or the biggest one is that hospital medicine is the fastest growing specialty in the United States. Current estimates put the number of hospitalists at about 50,000. The Society of Hospital Medicine has about 15,000 members. So you can see that there are many physicians practicing as hospitalists who are not members of the Society of Hospital Medicine. So I will say that one of my biggest challenges and a top priority is to tap into our broader membership to turn them into members of the Society of Hospital Medicine. So that's a big one. A second one is I believe that there are many physicians practicing as hospitalists internationally. And so a second big challenge will be to support the international hospitalists out there in promoting this field in their countries, in legitimizing this field in their countries. Yeah, absolutely. This model, yes, it has transformed healthcare. In the mid 1990s in the US, we moved to a focus of focus on patient safety, focus on quality, and hospital medicine became the model that was able to deliver that. As I mentioned earlier, a hospitalist with a focus on the inpatient side can focus on the rules and regulations on the inpatient side. The outpatient doctor can do that in the outpatient world. And so, we now have a model of care where in the US, we now have things like quality-based revenue, where our Center for Medicare and Medicaid Services, this is the closest that we get to universal healthcare. I know in Europe you have universal healthcare, in the US not so much, but Medicare and Medicaid is the closest that we get to it. But these systems can now hold practices, both inpatient and hospitals and outpatient, to quality-based metrics. Historically they couldn't do that so well, but now that we have this focus in the US, we are held to quality-based metrics like, ensuring that patients have a length of stay that makes sense, reducing readmissions, but we are also held to other metrics like patient-centered care and making sure that patients have a great experience when they're in the hospital. Mm-hmm. We can be held to these kinds of standards, because we have hospitalists in hospitals, focusing on these things. How we would integrate this system. So there are some hospitalists there. The way they have started integrating hospital medicine in Spain is through co-management. So for example, a patient comes to a surgical service, but we all know that, patients are very complicated, as I just said. If, for example, a patient who is maybe 70 years old has a syncopal episode, so they pass out, they fall, and they break their hip, they will go to the orthopedic service. However, for such a patient, it's critical to have good outcomes if they have an internist co-managing with them, because we need to understand, why did this person pass out? Was it a heart problem? Was there an infectious problem? You could consult 5 different services, but at the end of the day, someone needs to help coordinate all of this. And so Spain is doing a very brilliant thing where some internists who are starting to identify as hospitalists are providing co-management with surgical services. That is the entry point for Spain. Here locally, I'd say, because networking is important in general, in hospital medicine in particular, because, when you network, you learn different and perhaps better ways of doing things. Hospital medicine is about improving the provision of care of hospitalized patients, but even going beyond that, improving the provision of care of patients who are acutely ill. And so without networking, I may not learn what my colleague in a different institution has figured out about doing something better that I'm struggling with. And I think we can all agree that we can learn from practice beyond our borders here in the United States. That's why the international networking is important as well. So for example, I know in Spain, you've been doing hospital at home for years and years and years, and you're doing it amazingly well. The concept of hospital at home is starting to pick up in the last few years here in the US. So why do we need to completely reinvent that wheel if Spain has figured out how to do it, right? We might as well network, learn from what Spain is doing, so that we adopt that model and move on to the next problem to solve. And so I think networking is important because it just helps us learn best practice. It helps us improve on what we are doing, and it just makes sense, particularly in our field, where really we are charged with improving how we care for our patients. Mm-hmm. I think hospital medicine is here to stay, but we may evolve. In fact, we are already evolving to improve the care of patients beyond the four walls of the hospital. In 1996, back when this term was coined, hospital medicine was about practicing in hospitals, improving the care of hospitalized patients, improving the provision of care of hospitalized patients. More and more, and certainly in our future, we are starting to think about acutely ill patients and where we can best provide that care, and that is not necessarily always in the hospital. Sometimes that might be in the home, so hospital at home. Sometimes that is in post-acute facilities. Sometimes that might even be a little bit of outpatient clinic. Over the past 25 plus years, it's become evident that this model of practice is promoting quality, it's promoting safety, it's providing high value care to some extent by reducing cost. And so really, I will say that it's a model that makes sense. This has already started, but will become more concrete. We'll talk about acute care medicine. We'll talk about our practice really being beyond the four walls of the hospital. So that is the future that I see for us. Mm-hmm. A second future that I see for us is being more and more international. We do have some countries that are starting to think about this model. Spain is one of them. But I see a future where we have more international chapters of hospital medicine, where internists who practice as hospitalists recognize that they are hospitalists and call themselves hospitalists. So I do see that as a future as well.
We hope so too. It's been a pleasure, Dr. Kisuule, talking with you about precisely the development of hospital medicine and knowing your view as a president of the society. Thank you so much.
Well, thank you so much for having me.